Hey, welcome everybody. so
All right, so we were lecturing here for
we're
15
we're so
minutes.
sorry. We're so sorry, but you know what? We're not going to mess around with that. We're going to start off by welcoming everybody to this webinar. Whether it's morning, lunch, or dinner,
I hope
we're
I
happy
hope
for
you're
you to be with
safe.
us.
I hope you're having a good time. Just try
Yes.
to sit back and relax because we're lecturing for 15 minutes. I have
Yeah.
no idea that it was not
But we're
going.
good. We're good.
So
So let's move forward. So this is part two of a two-part series, and part one was in January, where we lectured on the full arch workflow utilizing Smile in the Box,
yeah, that's
right?
true.
And this is a technique where we can go through the full steps of bone reduction, implant positioning, and delivery of a interim restoration.
But today is a different
Yeah,
topic.
we're moving actually to a day that I'm a little more excited about because we're doing this workflow in our practice more and more every day, whether it is for provisional restorations or customized healing components. This single tooth workflow is something that's being integrated into our curriculum with our residents and so forth. And to kind of give you an idea, we come to you from Gainesville, Florida, the east coast of Florida. It's now 7:25 here, and we have an implant center where we have residents that go through. We treat patients 5 days a week, and quite a often use this workflow in the treatment of patients. And to kind of get on the topic of the night, many of you feel this maybe feeling this pressure for change. It's hitting all of us in our practices.
For sure, in different aspects, if it's from the patients, it's from our peers. But, it's a good thing because it moves our specialty forward.
Yeah.
You just need to be careful sometimes and try to do what we're doing here today is discuss, this aspects, those new things, try to evolve, try to educate, try to get better. So this is one of the reasons that sometimes we move forward to things like that. And you will see on the next slide, all the aspects, all different aspects of implant dentistry may be influenced by that.
Yeah, this pressure doesn't only come from, oh, do I integrate the digital workflow? This pressure can come from technology as far as dental implants, the change in the morphology, the surface, the prosthetic connection. All of these things can change how our practice evolves. But this doesn't mean as new technology comes out, you abandon the previous, right?
For sure, and it's something that we really have it implement on our practice. Each one of those new tools that show up for us, we found to fill gaps, right? We found situations that we can offer the best for our patients, but without forgetting the other one. Because when you have just one thing and you try to fit everything to that one thing, it's dangerous.
Yeah, one screw is not for everything.
No, for sure.
In addition to that, there's changes in techniques and materials. So, for example, I'm on the restorative side of dentistry, and the amount of materials and abutments we've had to choose from over the last decade has been quite dramatic and would lead.
Catalog just
Yeah, yeah. So we have to find indications for these, and this type of change is not too drastic. So, for example, if we were at a meeting together and I was sharing with you, oh, I've just tried this variobase abutment, and this translucent zirconium material is amazing on it. You could say, oh, you know what? I'll give that one a try.
I'll do
Not
one
too,
case.
yeah, not too difficult. I'll do one patient treatment, right? So, but when we say, oh, hey, I just picked up this 3D printer, it's amazing. It's changed my practice. You're like, oh. Am I going to make that investment?
You better.
So I think the pressure we have is in this technology from an equipment standpoint. The reality, though, this equipment can make a big change in the practice.
Sure.
And with where we're at with COVID-19, streamlining patient care, maybe minimizing patient visit time, or all the things that come along with the benefits of digital technology may be rather important.
Yeah,
It's
we're
just
already
hard to make that investment now
for sure.
because we're all struggling.
But we're already seeing where this gonna help us once we start seeing patients back. Right.
Well, we were seeing it beforehand, right? We saw increase in patients' treatment acceptance when we could present a treatment plan from a digital format. Patients are kind of more accepting of avatars.
Yeah.
They see a scan on the screen and they say, "Wow, that's me," and we say, "Yeah, that's you," and this is exactly where we would like to position your implant, and this is where we want your restoration, it's much different than holding articulated casts or showing them some pictures.
Making
Being
a
able to turn it
drawing.
around, we've had a major increase in patient acceptance when we present digital treatment plans. In addition to that, it's helped us very much with our pricing, right?
Yeah, because sometimes, especially in those more complex cases, it's really hard to gauge how many parts you're going to use, what parts you're going to
Yeah.
use, what kind of a lab fee you're going to have.
Or when you're gonna have to graft or not,
Exactly.
right? Or how many implants and
And
what
patients want to
length.
know.
Yes.
Patients want to. We all want to know. I want to
Yeah.
know how much this is going to cost.
And accurately is a it has an asterisk by it, right? I mean, because we're dealing with a human situation, so things can change, but it definitely helps us narrow the field quite a bit. In addition to that, I think when we move into what we're going to be discussing today, immediate treatment protocols, without a question, the digital workflow helps us prepare more effectively for it, and also helps us in executing it.
Yeah, I
Right?
hope it helps you to predict some cases, right? So maybe eliminate the cases that are not good cases, because we know how hard it's to, plan on our practice, block time to do a specific procedure, and then like you were waiting for me to finish the surgery, and I'm telling you, well, actually, it's not gonna happen.
Yeah.
You can load that patient, and you're like, I just blocked 2, 3 hours of my day to do
Yeah,
that.
so it becomes an
Mhm.
expensive mistake.
And
So this definitely helps minimize those
For
issues.
sure. And then the last one we have, to put out there, flapless surgery, flapless approach. And when we're doing those procedures that will involve you working without seeing the anatomic structures, right? The adjacent teeth, without having access to that, we highly encourage you to work with digital, work with 3D planning, because it's too dangerous if not.
Yes. So what are we going to cover in the next less than an hour? But what are we going to cover in roughly the next hour? One, we're going to talk a little bit about immediacy in dental implants,
For
right?
sure.
And define the placement and loading protocols, because this is a key component in utilizing this digital workflow effectively. The second area we're going to cover is actually the digital workflow. So we'll hit some key parts of integrating that into our practice, right?
Yeah, and then how it compares with the analog workflow.
Yes, and in addition to that, we'll talk about some of the limitations that we have with fully guided procedures.
Nothing's perfect.
Nothing's perfect, so you have to go into this eyes wide open. The third section is going to be where we focus on smile in the box, and actually, you're going to hear the word synergy, and synergy is actually the backbones of how smile in the box will provide for you a provisional restoration in conjunction with a template prior to surgery. Synergy, when you have certain components within the Straumann system, you could also do it in office. So we'll talk about those things with uh, in preparation and also with some patient treatment examples.
Yeah,
Right.
for sure.
So let's start with the first section. We're going to talk a little bit about immediacy with dental implants.
Well, it's always a question that we have: who, when, how I select those patients, what patients should I do this procedure or not. This is a topic for a whole lecture, for a whole day of having this discussion. I'm gonna try to share with you a little bit and how we go and why we do that. And I hope you will come with the own guidelines for your practice as well, your own approach. But decreasing time for patients, it's something that we already discussed. That's one of the reasons that we embark on this adventure. Decrease the trauma in some surgical procedures, and that goes together what we mentioned before with the flapless procedures. If you have a good indication to do this flapless procedure, and associated with that, maybe the healing, improve the healing, less discomfort, less pain, and maybe less healing time for some of our patients. And they're very popular with patients, right? I don't like to have patients dictating some of my decisions, but it's important to hear. It's important to be ready that to answer some of those questions, because patients are getting exposed to that, right? Through social media, through the television and other things like that. But it is very attractive. You come in, you leave with something, even psychologically, it's really good for
Well,
patients.
I think from a restorative standpoint, there's a lot of advantages that we have to immediates, and that is we initiate the tissue shaping sooner, which allows us to get to a definitive restoration sooner. So from a restorative standpoint, it's attractive as well. But the main thing is it falls on the shoulders of the clinician to determine, is this a proper treatment for this particular patient given the clinical situation. So and in general, immediate implants fall into several categories, right?
Yeah. So, important to remember that you have placement that can be done in different times too. You have loading. And maybe you want to associate those two. Maybe you have a good situation that you can associate placement and loading. Well, this is a slide that demonstrate here kind of like the roadmap, right?
Yeah, so this kind of highlights what we would be shooting for today and discussing small in the box workflow. Now, this is not an immediate placement, as you can see here. This is in a healed site, but this would show the process of going through the steps and pre-planning the implant, pre-designing the restoration, and then taking the surgical template and the prefabricated restoration to surgery.
In the
Or in some
surgery.
situations, it may be a customized healing component. And these photos have been shared with us from our colleagues up in Harvard, Herman Galucci and Adam Hamilton, have been doing a similar type of synergy workflow in collaboration for the last couple of years.
Yeah.
But one of the key factors, I think, where this hits home the most is in immediate placement situations. So in order to understand that best, let's talk a little bit about immediate placement.
So I'm gonna just cite a couple of publications here, and this first one that comes from the European Workshop of Periodontology, just dividing different categories, the timing for implant placement. We're gonna focus today, going to stay today a little bit more on the immediacy, right? The immediate implant placement. And keep in mind that you have other options, as you just mentioned in the previous case. You may want to, graft aside, or you may want to wait and do like a type 2 or type 3 placement. When we discuss immediate placement of implants, it's very important to remember that the key aspects for success in any type of osseointegrated implant still play a big role. And one of the first ones is primary stability. All right. This is a paper from Joseph Kahn group that really help us to train our eyes, I think, when you start evaluating those patients with three-dimensional imaging and try to separate them in categories. And he classified class 1, 2, and 3, and 4. And just looking at that, if you work with dental implant surgery, that class 1 will be way easier to achieve primary stability compared to a class 4. Right?
No question.
Luckily, most of our patients, if you look at that little table there, most of our patients present with a class 1. Right? But a good number of patients do present with some of the classes that will probably not be, the first indication for your immediate placement. Right? Other things that I think we agree on the literature, that is the preservation of the facial bone. Right? So a minimal traumatic process to do the tooth extraction, right? And try to preserve the soft tissue and the hard tissue. Having a facial bone thickness, we can have some different numbers here, but having some kind of facial bone thickness, maybe more than 1 millimeter, right? That can help you for the long-term success. And then sometimes even compensate for some of like the soft tissue and then hard tissue as well, increase the bulkiness of that or graft the gap. And this is something that we quite change over the years, right? Is the maintenance of that space or gap or HDD between the implant and the facial bone wall. Maintaining that space so you can fill that space with a bone substitute material, right? Instead of putting an implant that would fill the whole socket, right? Something that maybe we tried in the past and we learned the hard way that not the best idea. So the decision making, right, on our practice that I'd like to share with you, and maybe you can, complement other things there. But we started with the evaluation, and we started even with the radiographic evaluation. Put the patient on that cons paper with the classification of the remaining bone for primary stability, the facial bone, the position of the facial bone in relationship with the mucosa margin, right? With the proposed margin for your restoration. ability to achieve primary stability, and to have that gap or HDD that's maybe 2 millimeters. And that can influence even the decision for the size of the implant, the diameter of the implant. If you have those things, maybe we can move to immediate placement. We think that you should always at least consider, right, immediate placement. There is a lot of benefits for the patient. It's not for every patient, but you should at least have on your decision as part, right? Then you have situations that you can do that because the things that we discussed on the left side are missing, right? So you will make a decision to maybe wait and go for a type 2 or type 3 placement, right? 6 to 12 weeks. Or after that, maybe a full graft. Or even another route will be do a graft at the time of the extraction. We'll wait some time. And those two pathways will lead to a third procedure to place an implant, right? Different materials, maybe different times, but it's just important to discuss that, and that you have that. We're not going to spend too much time today.
No, for the purpose of today, we're going to really follow the green line.
There you go.
The green path.
We're going to stay here on the
So
green
these
path.
are the patients you would be seeking if you're going to do a synergistic workflow.
Yeah, we just want to create a curiosity for you to explore a little bit more the topic and understand that this is not a procedure for every patient, but it's a great procedure for some patients that have a good indication, right? So those pictures here, they're going to start rolling in. They just describe the step-by-step on a similar presentation, a similar patient. So maybe a premolar that's failing, you evaluate, you have good bone, extract the tooth, and then you place your implant using a guide. What you're not seeing here, but using the guide, you confirm the gap, you grafting the gap, and then you're waiting for healing. The part that we want to present today different is, okay, what else could you do at that point? So you could maybe load that implant and deliver a restoration. Well, Gonzaga, I don't feel comfortable doing that for a lot of reasons. And I agree with you. I didn't feel that day for this patient. But what I look back and I could have done for this patient is a custom healing cap, right? Something that will preserve the soft tissue contours. And we're going to discuss a little bit of that as well. But life goes on and this patient heals uneventfully, right? Everything is doing well. It's time to fabricate a provisional, what is it's a strong component of our practice.
It's a mandatory component, I would say. I mean, if we place an implant, usually we're going to go through a tissue shaping process. It's only fair to our technicians to provide them with ideal contours so they can give us the best restoration.
Yeah, and then you see here some of the contours, some of the approach, trying to have a less abrupt emergence profile and try to shape the tissues. And this is 10 weeks later. This patient actually was it is part of the study. So we had a protocol to have a 3D imaging at that time of loading. And you can see that still like the remodeling of the bone, it's happened. We have part of the bone that was grafted there on the HDD, and we go all the way to delivery. Delivery was done at 14 weeks just because laboratory procedures and get to our schedule. But the patient was on provision during this whole time. And you see the final restoration done, screw retain with I can't remember if that was, I think it's pre-type base.
Well, this is a metal ceramic, yeah. So in that study we did a certain number of gold abutments and certain number of variabase, and this one was a metal ceramic restoration.
And then we have a 3-year follow-up with a new CT as well. And you see even, good selection, good implant position, the use of a biomaterial on the gap. There is a minimal change. There is some change that happened with the bone, but it's stable, it's healthy, patient is happy. And it's a really good example of a success in such approach.
I think one of the key factors, though, is, and this comes from one of the recent publications from the ITI Consensus Conference 2018, is really understanding placement and loading.
Yes.
And Herman Galucci, who is the head of this group that looked at that, felt really passionate about the fact that there's always a timing of loading associated with every placement.
Yeah.
So they should be considered together.
And
right?
sometimes that's not clear in the
And
publications.
it's not clear in the publication, right? So there's going to be loading associated with every placement, and so you have to kind of interrelate them, right?
Yes.
And this is what this paper highlights. A very a must read for you if you do anything with immediate implants, and you can get it for free from the iti.org website under the consensus conference.
So not going to spend too much time here, but you have your late implant placement. So as Will was saying, placement protocols, not loading protocols. Placement protocols, late, early, immediate, right? Late, anything more than 6 months, maybe different reasons. Maybe your clinic got shut down because of pandemic, and you could not place an implant on a patient,
Yes.
right? Different reasons for have late implant placement, early implant placement, different indications too. Very popularized by the group at the Universal Burn. 4 all the way to 16 weeks, depending on soft tissue or a little of a hard tissue healing. And then you have immediate placement that, by definition, is the placement of the implant associated with the process of extracting the tooth. So one surgical procedure to extract the tooth in place. Loading protocols now can be permuted, can be associated with placing protocols, can be divided in conventional loading that with modern implants today, especially with the Straumann S-selected surface, even before with the SLA surface, well established, well published. It's not just like something cutting edge, something new. It's there. And if you're not doing already, you may,
Well, you're talking about 8 weeks. Conventional loading, the publication highlights 8 weeks, and there's many people I know out there that are waiting 12 weeks to load implants routinely that have been placed in healed sites with primary stability. So when you look at the information coming from the ITI, that
yeah.
is evidence based and expert based information with a consensus conference recommending 2 months or after. That's a pretty powerful.
Well, when I'm not that old, and when I started doing like an implant dentistry, conventional load was 3 to 6 months.
Yeah.
Right?
Yeah,
Depending
you
on
are
the
getting old though.
I am getting older.
Yes.
The other
So-
option is really bad.
Yeah, I'm much older,
Yeah.
and I feel it.
So
So-
early loading, as you perfectly define, 1 week up to 2 months. Very, very popular on our practice, and normally it happens between 6 to 8 weeks, right? On our
Yeah, I would
practice.
say we're still in between conventional and early, and one of the difficult things is well, no, actually early mostly, but
Yeah.
the difficult thing is actually scheduling the patient.
Yeah.
Sometimes you're booking further out than that time, so it gets difficult to do that. But that's where you have the benefits of immediate in when indicated.
And on immediate here, one of the changes was extending the time for immediate loading all the way to 1 week. It used to be some of the publications 72 hours, 48 hours, 1 week. Enough evidence today that with 1 week, if you have primary stability at the time of placement, it will maintain to that
Yeah.
week, and you can proceed with that. So you can here impress. You can do other procedures maybe with your lab that allows you more time to deliver that restoration. And this is the cherry on top of this publication. I think it's such a cool table that Galucci's group put together that for us, right, at health professionals, we try to work in the evidence base. So here you have in green the permutations, the combinations. They're well published. They have good evidence on the literature. Yellow, median level of evidence, and then red, poor evidence on the literature.
I think what's important to point out in this publication, it's the first one to bring immediate placement and loading together. So you see along the top bar the loading protocol, the sidebar, the placement protocol, and you have all these versions: type 1A, 1B, 1C, type 2 to 3, A, B, and C, and type 4. So you see how they interrelate, and the literature review on this was very powerful
Yeah.
and involved to be able to get these numbers. This doesn't mean if it's red that it's
Don't
never
do it.
done.
Doesn't mean don't do it.
But there's just not much literature out there to
Understand,
support
yeah.
it. And you think in these situations you're not most often when you do early placement, you're grafting.
Yeah.
And they're not a good indication for restoration or loading.
Mm.
So it kind of falls in line with a lot of the clinical approaches that we
Keep in
use.
mind though, conventional loading, keep in mind, conventional loading, it's anything more than 2 months.
Yeah.
So, we need to change that mindset that conventional loading is 3 months, 6 months, right? You're just waiting, maybe you're waiting 10 weeks,
Yep.
12 weeks, it's conventional loading, right?
So on a side note, just so everybody knows that's joined us tonight, on the last slide, before we start answering questions, there'll be a QR code and a link for you to download the notes for today, so, or this evening. So don't worry if there's stuff on the screen. If you're trying to write it down or you're doing screenshots, you'll be getting
A
PDF.
PDF, yeah.
So let's move into the digital workflow. We're all very comfortable with the analog steps in the process, whether we're collecting data, planning for implants, or executing and restoring the procedure. And then you have a parallel universe that's floating along with it that allows digital steps to occur. And I could tell you about 6 to 7 years ago, this was hard to have this workflow stay in line. Most often what we found from our colleagues, there was crossover that occurred between analog and digital steps. And whenever we have one of these crossovers, some believe that we introduce some error into the system. So the more we can stay on one side, the less, and that being the digital side, the less potential error we may introduce. What you see here in the green lines are probably the most common pathway we have with the single tooth workflow that we're discussing today. So we're very heavily forced into digital diagnostics. The A stands for acquisition of information. The P stands for planning. And the S is the surgery, and the R is restoration. So where our biggest gap has been is where you see the dotted lines in the prefabrication of restorations.
Yeah. And you need to understand that Will mentioned before, fabricating provisionals it's a very strong part of our beliefs and our philosophy. So that's something that it slowly we're incorporating on the digital workflow, but it was the biggest hiccup.
Yeah. So where are our colleagues in the digital workflow? This is some data that came out of Harvard back, and if you look at the dates from 2012 to 2016, and I got to tell you, our numbers would have been much less than what you see on the screen here. So in Harvard, they were 60% of the time using intraoral scanners, 85% of virtual planning, and you can see the digital prosthodontics and the 41%, guided surgery about 28%. I would think that if we got the numbers today from Harvard, all of these will be advanced quite a bit.
Yeah.
Because if you look at the numbers in the implant center alone associated with CT guided surgery, we've had an increase in just a 1 year span of what's that, like sixfold in CT guided surgery. And if we looked at our 2019 to 2020 data, which we'll work on getting together, I would say we've moved up from 61% to 85 to 90% CT guided surgery. Now, this is not because Luis and I are telling the residents, do it. It's just this natural evolution that's occurring. We're doing more CTs on patients. When we do a CT on a patient and an intraoral scan, we import it into the planning software. If we import it in the planning software, then it's a natural evolution to start printing it. If we have a printer, it becomes more work to go back to analog because you lose the benefits of that virtual planning. So the key point here is introducing the digital workflow is embracing digital acquisition or getting the information of your patient converted to digital data as soon as possible, creating that virtual patient. And once you have that virtual patient, whether you invest in the software to do the planning or you outsource it, it gets you in that digital workflow. And that's one of the keys.
Don't feel pressure that are like, oh, do I need to have everything? Do I need to have all the steps? Now, well, we show like the digital pathway, the analog, and it's like there is all those steps. You still can do all those steps outsourcing.
Yes.
The step that you cannot do outsourcing, or actually you can send the patient to a clinic or something, but you need to create that, STL file, DICOM files. You need to create that information to the patient so he can navigate through the computers.
Yep. So often the question as well is CT guided surgery that accurate? Is it something that we should incorporate? This was a nice study that
Now look at that and look at
that
the accuracy of free-handing placing osteotomy and placing the implants versus using a guide just for a pilot drill and then removing the guide and doing the rest free-handed.
understanding that fully guided incorporates the placement of the implant through the static guide. So one is completely free-handed, and one is the last one that you see fully guided would be completely through the template.
Exactly.
Now, in this study, they were planning for screw-retained restoration of the posterior mandible. These photos you see on the screen here are just from our clinical
Our
base.
yeah.
So they were studying the placement of the posterior mandible for, I think it was a 3 and a fixed partial denture,
Mm-hmm.
and looking at the deviations that they had in all these forms here, which you'll see on the screen. What's important to note from this is every implant was restored. Um, the plan was for screw retained. The only patient base that had 100% screw retained were the pilot guided and the fully guided. The free-handed, some of them had to be custom abutments and cement retained. So there were some angulation issues there. But when you look at significance, really on the screen here, you can see between the red boxes and the blue boxes the areas that were significant, and it only occurred between free-handed and fully guided.
Yeah.
Right. So there is a process where you may be able to prepare an accurate osteotomy, but then the placement of the implant, if it's not being guided in, you have a potential error in angulation deviation, and that may even occur more often than in immediate sites that have extraction
Media
sites.
sides, like poor bone quality. So there is a lot of things that can play a role, even like the position of the side of the mouth,
Yeah.
right? The access to it. But important to highlight too that even on the fully guided group, you see numbers that are not zero,
Yeah.
right? So it is not perfect, and that's why we always work with safety zones.
Yes.
We work with safety areas.
And this transcends to a systematic review by our colleagues Ali Tamasab
Yeah.
and Daniel Vismeyer
In
and
the
others.
Netherlands.
This came from another consensus conference publication. And in this publication, they defined the types of templates we would use. And actually, the reason why you don't see haptic here is because haptic really isn't a template, right? You're not or maybe it'll fall under dynamic. It'd be a navigation of some sort. So we have a growing evolution of haptic guided surgery here in the States, as well as dynamic is getting a resurgence. But the reality is right now, most of our templates are being placed through static guides. And there's one advantage to a static guide, and that is capturing the exact timing if we're going to be doing the procedure we're talking about today, which is going to be the synergy procedure. You have to have accurate timing of the implant positioning to deliver a restoration.
Yeah. We would not be here giving you this presentation if we couldn't do that.
Yeah. So this study highlighted differences between the different approaches. Very difficult to compare them all together. But what we want to highlight here is that this review also supported what we just found in the previous one. Guided surgery gives you more accuracy than free-handed placement. And there are some variations in the type of guide support. So placing templates on bone comes with some potential error, but we're not worried about that with this discussion because all these templates are going to be on teeth, which give us high accuracy. But understand here that we have deviations and error, just like you said, Luis, is you have to have safety zones. It's not a completely perfect system, right? And there's a variation of templates that can be designed. I think this is where I get very excited is with the introduction of digital planning and the introduction of additive manufacturing and 3D printing. We can just design a whole slew of different types of templates that we can introduce into the patient treatment scenario.
Yeah, and if you spend a little time talking with the guys from Straumann, Philippe and Julie, it will hurt your brain all the things that they can come up to design guides for you. So.
Yeah, and Philippe and Julie are with the Smile in the Box team, right?
Yeah.
That you would be talking to. I think where we saw the biggest change in our practice was when we acquired our 3D printers. We have two 3D printers here, the Straumann P20, and we have a Formlab 2. And just the introduction of these allowed us to keep a lot of this in house and make it very efficient. This printer will print our templates in less than 20 minutes, 17 minutes. We could see a patient in the morning and have CT guided surgery in the afternoon if we felt so that we wanted to. So a lot of advantages to this workflow, and actually another study coming out from our colleagues in Harvard, and the reason we keep referencing them, one, they give us good stuff, but Adam Hamilton was one of our previous scholars here, and we followed him up to Harvard, and he just puts out some good stuff. And one of the things they were looking at here was, is it really tied to, do you need a Lamborghini type printer to get accurate surgery, right?
Yes. How much, the difference between the more affordable to the very expensive one. And on this study, they show actually that are not a lot of difference. Those are all three really good printers, though.
Three very good
Just-
SLA printers.
It's not like one that it's really bad here, but the one that's more affordable. And they look at back, they compare the treatment plan versus what was executed, and the discrepancies, the difference were minimal. And like Will was saying, maybe the best way to measure those things is, did you execute your plan? Was your plan to do a screw retain restoration and use a very base abutment, right? A regular abutment? Or
There's
did you end
also
up?
one other big difference, right? I mean, if I gave you an Apple iPhone 1, it's gonna work, right?
Yeah,
It's gonna work really slow,
it will.
right? So some of these printers, like the less expensive one, it may take you, how was it for the Forma 2? Was it 45 minutes
Yeah,
when
that's
we
a
were
good.
when we were going with the kind of validated workflow,
Yeah,
and time becomes very, very critical when
yeah.
once you get comfortable with it. The day you get the printer, you're like, oh, this is amazing. Next thing you know, within a week, you're like,
So there's
I
more.
want it yesterday.
Yeah, there's more things that you get to other than the accuracy, but this makes you feel a little more comfortable in the fact that if you invest some money, at least on
Yeah.
a good printer, you can get similar accuracy to execute some of those plans that you will get to a very expensive one.
So before we get into the small in the box workflow and synergy, we want to talk about some limitations, because everything is not Sundays and happiness and sprinkles
Yeah.
and so forth. And one of the things is there's time in this workflow. I mean, you have to invest some time, and there is some cost associated with it. We're not in the business of paying for this type of treatment. We have an added cost for our patients when we do this, and this is something you'll find out. But the patients value this service, the way that we present it. Remember earlier how we told you we presented these digital workflows, and they see a value in that. So patients in our practice are going to pay for a template no matter what. If we're not doing CT guided surgery, we're making plain film templates. So they're paying for a template, and we're going to use the template. It's just going to be, there's costs associated with it. But one thing that will be more embarrassing than anything is you do a digital treatment plan.
Spend time.
You
money.
spend time. You tell the patient how important it is to use this CT guided surgery template. We want the best for you. We want this accurate position, and then you can't use it. That's a bad day, right? So the patient invested that money, and then you get to surgery and you have no access. You can't get in there. So using any instrument that gives you the confirmation of access is very critical. And we use this diagnostic tee from Straumann that gives us 32 millimeters. And you have to be able to get in there and have access for this template to work.
Exactly.
Naturally, as we get posterior, it gets more difficult, right?
Key, unfortunately, we had situations that we learned this on the hardest way, like we'll describe. We're planning with the student, we go to surgery, and it missed our checklist. So highly recommend you add to your checklist there when you're planning with the patient, when you're starting to at least in any kind of implant placement or unguided implant placement, maybe more because you have more material, more bulkiness that goes there in the mouth, so you're losing some of the space. But it's always good to confirm that you have the minimum amount of opening to
And
execute.
the other thing that's really important is these templates don't make up for human error.
No.
These templates don't make up for not thinking through the process, going through your checklist scenario. And one checklist scenario should be, is the template seated?
Yeah, look at this picture very carefully on you guys' screens, and you will see that those cuts, right, those openings, those windows were created so you can verify that there is a tight sitting, and there's no space in between the template and the tooth that are supported. So it helps you to confirm. And sometimes soft tissue, even the way that you do the anesthesia, maybe the teeth move. There are so many things that can influence that, discrepancies on the printing and things like that. But you need to be able to confirm that. You need to add on your checklist as well. Is the guide seated? Is
Is
the
it fully
guide
seated
fully
before you?
seated?
So move one step
Attention
to
to
another.
detail. Attention detail.
So one of the other situations that can happen with CT guided surgery, and this is kind of like the elephant in the room, because I know many people that do CT guided surgery, they run into these problems. Everybody's going to do it at one point, and that is how we can generate more heat at the osteotomy site,
Yeah.
right? Because so much of that comes in line with the design of the guide. But in addition to that, when you get to these surgical procedures and you have a prescription, and the prescription is use this twist drill and just take it all the way. If you're doing go to full depth, if you're doing several implants, you get into it's like a Indy
No-brainer.
500 race.
Yeah.
How fast can you get through this process? And you forget the fact that you're dealing with vital bone. And when I say that not because I think that happens. I've seen it happen. I've seen it happen with clinicians that get so comfortable with it, they're moving too fast, and they're generating heat. And all of these factors that you see on the screen here can lead to heat generation. This, what you see on the radiograph there, is an implant that's failed 6 weeks after placement. And I was at that surgery, and that thing was primary stable, and it was ready to be loaded. But I remember the osteotomy preparation, and it was a very aggressive preparation. A lot of pressure, a lot of heat, I think, was generated. In addition to that, the irrigation was not getting to the site. Irrigation becomes a very big component of minimizing this heat. Using sharp cutting instruments, making sure you don't put too much pressure. Those go without saying. But with a template in place, sometimes it's hard to irrigate. In addition to that, in flapless procedures.
Yes.
Right?
Then you introduce two things. So we put this slide here just to remind you that when you're using templates, when you're using those kind of guides, you may need to modify your technique to irrigate. You need to have that concern in mind that you need allowed for space, so your coolant, your saline is getting there.
And if you search the web, you'll find a bunch of different ingenious ideas on how to irrigate. We have some colleagues that are technicians that have come up with different techniques, metal templates that minimize tissue coverage, that allows irrigation much better. This is one that actually we found off the patent website, where they patent this approach to irrigating. Both, if you look at it, implants and endodontics. And this comes out of our colleagues in South Carolina. Just recently, one of our previous scholars, who's doing a residency up in Indiana right now, has submitted this for publication. And this technique is not placing an anchor pin through the osteotomy. It's just planning for one, but using that space to irrigate with a monojet syringe.
Yeah.
So it allows the assistant not to get in the way of visualizing that the template's fully seated and so forth by the operator. So this is a nice technique. But you know what? On the outside, Straumann has approached with their BLX implant. I think you'll see this come down the line, is creating twist drills that generate less heat.
Yeah, and this is a little video of the Velo drills, and they're already available at the BLX. But I had the feeling, maybe I'm saying something that should, but I had the feeling Straumann would just like roll this to the whole lineup implants at some point, because it just makes sense, right?
It because of the geometry of the flutes on this twist drill, it's much more effective drilling.
Spending more time
you spend less time in the osteotomy. That reduces the heat, and actually because of that, you actually can jump over sizes.
Yes. Right.
So a lot of advantages to this. I think that the timing of this couldn't be better, because when we use these fully guided systems, sometimes it's just very difficult to get the irrigation there. So this design may help quite a bit. So we're at the last section. We're very excited to talk a little bit about synergy and how it impacts our practice, and how you can use Smile in the Box to help you with it. So what we're going to discuss right now is the partially dentate workflow that's a fully digital workflow. And this synergy workflow gets you up to the provisional restoration. if you use it within Smile in the Box, and then you integrate your laboratory in executing the complete to the endpoint. So Straumann is really their Smile in the Box workflow is dedicated to get you to a provisional restoration at this point. So where is this in the literature? There's, to be honest with you, there's not a ton of information out there on the
Hard to do like
Yeah.
a randomized clinical trial or such thing. But we have actually a good number of case series and case reports that with the different aspects, maybe slightly different twists. They've been showing that it's possible to do. What we get here is bits and pieces of the literature that we present before. So understanding, case selection and how we're going to do that and putting that together with the digital. But you still need to be quite critical when doing that. But it's doable, and we'll show you how.
Yeah, so let's talk to you about the backbone. This is what happens on how to actually execute the process. What you have is you have two software systems that are fall under the line of
The Straumann family.
the Straumann family
Yeah.
in dental wings, and one is the CARE system, which is a computer-aided restorative design software that most laboratories have. And then you have the co-diagnostic software, which is the surgical planning software, which is becoming very popular. And if you place implants, a lot of people are utilizing the software. So what Synergy does is it links these two together. So on the CARE side, we introduce a surface scan.
Yeah, so you send to your lab, most likely your lab,
Your lab would do this.
your STL files of your patients,
Yes.
maybe some notes and maybe some digital photography, so you can translate, the vision that you have for the plan.
So the STL goes to the CARE software, and then on the co-diagnostic software, the CT is imported, tied to the patient. Obviously, they're tied to the patient. What will happen within the software programs is you select a Synergy link, and it actually links the two labs or the two clinics or whoever has the software. It doesn't matter where they are on this earth.
Yeah.
It links them together. And what the process is initiated by is it's initiated by a restoration. So the lab will start off with doing a rough wax up, or it could be a detailed wax up of where we want the tooth to
And
be.
it's exactly what we keep preaching, right? So that's
Yes.
what this workflow makes so much sense, because it forces you to plan a restoration first.
Yes. And then when the co-diagnostic software is opened up by the surgeon, the software, the wax up is automatically imported into that plan as a segmentation. Right?
Yeah,
So
so
you have the wax up there, and now the surgeon can initiate the implant positioning. Right.
yeah,
So the surgeon will go through the process based upon that restoration of selecting an implant, positioning the implant, and getting to the point where they feel comfortable based upon the restoration, the available anatomy, where the implant may go.
yeah. Once you select that implant, you finish the final position of that implant. You locked in the implant, so you're not gonna touch it anymore, and that information gets linked back to the lab technician, or the person that's working with cares. And now for that part of the process, it's like you
We're
impress
working
a
with a final
patient.
restoration.
Yeah, that implant's already
Yeah.
there.
Once that implant is locked in the co-diagnostic software, the technician they could fabricate a definitive restoration, but we're fabricating customized healing abutments and provisionals. Now, what's important to note is that you can go back and forth and move the implant and discuss it with the technician before you lock it as much as you want. Every time the software is opened, it resets,
Yeah.
and you could even be on there live. So we have both programs here at the university, and we run it on the same computer, and you can see things moving live. And we'll demo that in a minute. But once everything is locked and the restoration is finally designed, the implant is locked in place, now you can fabricate a template or design and print a template and then fabricate an interim restoration or customized healing abutment.
And that's what you're gonna have at the day of the surgery. So you're gonna have your template, your abutment, a restoration that most likely it's milled, and you get a prescription from the co-diagnostic software, the implant planning software, that tells the clinician that's doing the surgery exactly the sequence. You could even click there on boxes and order your implant
Yeah.
and all the materials needed for that surgery as well.
Yeah. So that takes us to the next point. If you're sitting here saying, that's all cool, guys, but I'm not going to run out and buy the software or get co-diagnostic, but I'd really love to try this workflow. And that's the important thing is how can you try this workflow and not invest a ton of money in the equipment. And
Yeah.
that is utilizing a service provider. And Strawman understands that, and that's how they've released this smile in the box workflow, which I think is only going to get bigger and bigger as time goes on. But what's nice about this, it's either full service or modular. You can say, hey, I just want you to do this for me, or hey, I want you to do everything for me, right?
Truly a la carte.
Yeah, it's a la carte. So everything we just showed you could take place at Strawman. All you would do is you would go to step one, upload your CT and your surface scan, and then write a prescription.
Yeah.
And this is what the prescription would look like right here. There we go.
Yeah, so this is just a screen recording of the website. It's all website based, so you don't need to have an app. You don't need to. You just need to open your browser, found there. Create the information for your patient. Creating your information. If you already have a Strawman account, it can be added there, so it's way quicker as well. And then you're gonna start deciding what kind of treatment you're gonna provide for your patient, right? So it's a single, it's multi-unit, it's a full arch. We already discussed full arch in the previous webinar. This time we're going to select a single, maybe it's on the maxilla. What kind of floating approach you want, Dr. Gonzaga? Well, planning to do immediate. Do you want a restoration or not? Yeah, we'd like to have a restoration. What kind of restoration? Screw retain or not? You can add more things. You could
hit other there and do customized healing components if you want as well.
You could. Select what implant type, implant platform you have in mind. And like I was saying, the implants, the abutments, everything can come with your order as well. So you don't need to do all this here. And remember to tell your implant coordinator, it's like, hey, we're going to need this implant for that day.
And the nice thing about that, though, is let's say you did order it all and you ordered the implant, but then you ended up using an implant from your stock, you could send that stuff back.
Yes. Yeah, that's what I was told.
As long as it's not open.
As long as
that's what we were told. Yeah. As long as it's not open, right?
You could.
So this is where you start creating your own mix and deciding if you're going to go with a modular service. There's several situations where we utilize Smile in the Box just to get to the templates. I mean, when we go with these elaborate stackable guides, and then have them send us STLs to print on our own printer.
We're using them to do the design.
Yeah, we just don't have enough time to do the design and sit down and do it. So obviously, we don't know the fees, but this is all vary based on your modular selection, if you're going to select everything or not. But what's really nice about this is it starts off with a CT and an STL that's uploaded, and then you go forward from there. So Luis is just showing you this endpoint. You can then once you're done, you validate it, and let's move forward to the next slide. So that was at the first step and second step. Then what happens is they go through a planning and design phase. They clean up the software, they do the wax up, they position the implant, and then you have to have a treatment call.
Exactly.
And the treatment call is important because I hear many people that get concerned about full service providers. They say, well, they're not dentists and they're planning the implant position. No, they're just doing all the busy work. So you can just roll in and just make a call and say, I like it or I don't like it. We've had several treatment calls where we've moved implants, we've changed treatment plans, and that's just what happens. But once you say that's good, then they move to the production phase, delivery, and then gets you ready for surgery. And you need about, how long do we need between 5 and 6? We give about how long?
Well, they ask when you put your prescription, you will put the day of the surgery.
And they work backwards.
And safe, it's like 4 weeks there for you to work out this, to have time to schedule. But I don't know, like now with the disruption and shipping, things may change. But it's not that long. Once you get approved the design and the ship, it can be 2-day shipping.
Yeah.
Right. But I think 4 weeks is quite safe. And then you get a box, right? Without that information, you will get an email too with the prescription, right? And all the details for your surgery. So you get screenshots, details, and on the mail, you get this box with all the things that you request. In this case, a guide, a abutment with the screw, an implant, and your provisional restoration.
I think one day we're going to be seeing the grafting material, custom graft blocks, screws, membranes. I mean, everything just coming all at once. Yeah. I mean, it's not far from getting to that point the minute you create a virtual patient. So this is an example of that synergy workflow, we have a course that we run here out of Gainesville, Florida, and this is showing one of the participants going through the process of preparing the site and the typodont, placing the implant, and then delivering the synergy provisional restoration. And in this course, they also did all the planning and everything leading up to this. This is a lot of fun, a 2-day course. If you're interested, you can reach out to us to get dates or ask Strawman. Lots of fun with that course, and then you leave with this information afterwards. So let's go through some patient treatment before we wrap it up, because this is where you get everything out of it. And we're going to show you this as a synergy workflow, which means we're doing this in-house and we're utilizing Strawman for just the milling of the restoration. But this could be the exact same way, this workflow you would do with Smile in the Box. So you first have to acquire information and get the CT file. Exactly. That's the first step, the acquisition. Then you would initiate the Smile in the Box workflow. For us, we initiate it in-house by making the provisional restoration and designing the surgical guide. They communicate together, and then once we lock it in, we go to the definitive components. So what we end up doing is we end up emailing and sending out for the provisional or custom healing abutment to be fabricated in the Arlington facility, and then we make the template in-house.
Yeah, we really like the quality, the materials that they use there to mill. It's much better for us than what we have available here. So we can have them doing that part. Like Will was saying, you can really pick and choose whatever you want to do.
Well, Luis, why don't you talk to us about one of our early treatments?
Yeah, so this patient, she presented with a fractured lateral incisor. Colleague in town diagnosed that the tooth was non-restorable and did this bonded restoration so the patient could go this happened on a Friday. Monday she came see us, and we go through the process that you highlight well with acquiring that information, getting a CBCT of the patient, evaluating is this at least possible to do it. Do we have enough bone? What is the anatomy of the root? Can we anchor an implant, size of implant, and so forth? So we go to that. We connect with the software that is doing the crown planning.
So what you see on the left is you actually see the co-diagnostic software. On the right, you see the care software, and they're linked up together at the same time. So you can see how it's real-time modification.
Yeah, first thing was there, get that information, put the implant in place based on the restoration. And now you see the emergence profile being developed, right? And this is extremely important once you have that implant in place, because sometimes you want to graft, sometimes you want to go with a more skinny approach. So there's a lot of things here that can happen. So the day of the surgery, we have the guide, we have the restoration not connected to the abutment yet. So it's always good to have a chance to verify, because you may need to do modifications. And as Will highlighted before, this is only possible if you can do the surgery fully guided. And this patient was right on the edge because it was a lateral incisor.
That's a tight site. Look at the sleeve there. I don't know if you can see our mouse, but the sleeve is right there. And then in the lower right-hand photo, and you can see that he's almost lining up the dots on the implant mount with the line on the template, and that's what transfers the timing. So when we put the abutment in, the tooth isn't crooked, right? Exactly. So timing is critical, and this static guide gives us the timing to align up with the CrossFit connection of this implant.
Perfect. So we did end up extracting tooth, placing the implant, confirming primary stability. ISQ values, insertion torque, whatever tools you utilize on your clinic to confirm that. And then this is the first time that abutment is being tried on the mouth, and then the crown goes over that abutment as well before being connected, just to confirm. Once we confirm that, there's two things happen. Outside of the mouth, the crown is being connected to the abutment, cemented to the abutment, where it can be done with flowable composite or a little bit of resin cement. It's like kind of your preference. Inside now, the graft of the gap has happened, sometimes even like management of the soft tissue. One of the limitations, that you guys have probably seen, I'm just going to point out the obvious, is the color. This is a monolithic milled material. We try to stain, we try to paint and do other things. I think the best results come sometimes from doing a cutback and putting a little bit of composite there, veneer of composite. But this is something that we'll see the evolution of, over time with blocks there have multiple layers and things like that.
Yeah, I think it only will improve.
Right. So this is 8 weeks, and this is for me the beauty of that, because the patient is healing, the implant is healing, primary stability is being turned and secondary stability or osseointegration. But by the time that you get osseointegration, your tissues are ready too. So this visit is to confirm osseointegration, remove the provisional for the first time, and actually find impression.
Yep.
So count in your mind the number of visits, right? We did the initial data, we scheduled the patient for the surgery, and then we're doing final impression.
But you did one follow-up, right?
We did one follow-up.
Yep. But now we're at a final impression stage.
Yeah. And then, a lot of times this design of the restoration, it's almost copy and paste. You could even use the same abutment. You would design in a more materials with more longevity. In this case, zirconium oxide and maybe lithium silicate. This patient was so happy that I want to bring her back to see that tissue fill that space, because you can see the papilla is filling the space from the palatal side. But she's like, why do I need to go back to Gainesville? And a lot of our patients, they drive.
It's a travel, a struggle for us, because our patients all drive 3, 4, 5 hours. They fly to us. Don't have many local patients. And
but I just took it as a compliment.
It's hard to get them back.
That she didn't want to come back because she was happy.
Yeah. So there you see the radiograph. Sorry, Luis.
That's okay. It was just a radiograph follow-up. You see, the maintenance of the bone levels, the good adaptation of the abutment, and so forth.
So there's two things. You can do this workflow. You can place the implant, and if you decide that the implant can't be restored, just set the provisional aside, and now you have a provisional for loading.
Yeah.
You don't have to worry about it. So for you surgeons out there that are catering to your referrals, just go ahead and do this, and then hold the template, the provisional aside. The other option is to kind of forego making a provisional and moving directly to a customized healing component, right?
So if you remember the table of placement and loading from the consensus group, immediate placement with immediate loading was in yellow, but on green on the top right of that table, you have immediate placement with conventional loading. So immediate placement with conventional loading, a lot of evidence, very safe. So maybe you want to do that, right? And still get really good benefits of putting a customized healing cap. That's what this pathway let you do it too. You, with a button, with a click, you can choose if you want the crown, or if you want just the same thing as the crown without the crown.
Without the crown. So you still have the same emergence, but you don't get the crown.
So tooth was extracted. Going to skip here. You know what happened with the guide. Same approach. Fully guided placement of the implant, so controlling the timing of the implant. And here you see your custom healing abutment. The gap was addressed with a bone. This is one of the publications that highlight this technique, some of the details when designing this custom healing abutment. This is another one. Gary Finel, he's a good friend out in France. And he does some really cool webinars for Straumann too. And he calls the SSA, the sealing socket abutment. The idea is the same, is to preserve that soft tissue, to maintain that soft tissue that's already there, shaped for you at the day of the surgery. All right, so 8, 10 weeks, 12 weeks after that, whatever, when you want, you can just remove this custom abutment and do your final impression. We had both fabricate for this case, for this patient. So at the day of final impression, we put the provision there so she didn't need to use her ASICs anymore and feel a little bit more comfortable.
Yeah, we want to end off with this one patient treatment, which is one of our most recent that we did with the Synergy workflow and utilizing a BLX implant. And this is a longtime patient of ours that came in with a tooth that was no longer salvageable. It's kind of gotten to the point where we're going to have to move forward to an implant. You can see everything else that's been done with her over the years. But we initiated the process again, just like we talked to you earlier with the intraoral scan and the wax up. So this is going through the wax up stage.
Yes.
And during this stage, we obviously have the opposing occlusion, and we can work things in all the detail we want. But what we're really trying to get to is just a rough idea where the tooth is going to be, highlighting, very critically highlighting where that planned mucosal margin is going to be, because that drives the depth positioning of the implant.
The zenith of the
Yes.
restoration is extremely important.
Extremely important. And then once that's done, it gets then forwarded onto the co-diagnostic software, where we went through the process of importing that wax up and then positioning an implant.
Because we want to do immediate placement of this implant and hopefully connected a restoration, we end up choosing a BLX design. So we design choose an implant with a design that is a little more aggressive, that hopefully will improve the primary stability and allowed us to move forward with connecting the restoration that same day.
Yeah, and absolutely, what's critical here is getting that vertical positioning right. So we utilize this user-defined abutment, and there's two components to it. There's a clinical component and a submucosal component. So we like this implant to be 3 millimeters apical to the planned mucosal margin. So you can see how we design that kind of triangle or that point. And that point becomes our measuring point to where we position it at the level where the planned mucosal margin is going to be. So that should be highlighted in the wax up.
Yeah.
Once that finalization is done, we confirm it on the restorative side, on the carrier software. We lock things down, and then we got to the point where we designed the template in-house, and then we sent the provisional be fabricated in Arlington.
So you're seeing here where the guys, in Canada, that's where like the design team is. They will be doing that for you, or if you want to invest in part of the software and be doing at your office or working with a lab technician, that's what's going to happen behind the scenes. Here is the portion of the software that allows you to design the guide. So choose what kind of guide design that you want.
So what you saw, okay, welcome back. We're back. So what you saw, go get the what is the ventilator? I think we need ventilators.
Oh man.
Or some fresh O2. So we just covered the final. We're not gonna show that video because I think that might have been what was a problem. But the video just showed the technician with the final designs of the emergence profile, and making a skinny emergence profile to keep the pressure at the crest of the ridge the most minimal.
Exactly.
We have what's come to us from our in-house lab with the template and Arlington in the provisional. If you were doing Synergy, this is what would be. If you were doing Smile in the Box, this is what you would be receiving. Exactly. In conjunction with whatever else you ordered. Now, what we also did in this situation is we poured up. Not poured up. We printed up a model.
It's our plan B. It's our contingency plan. Where this was on the beginning. This kid's probably almost, oh my god, a year and a half.
No, not this one. Not this. This is our BLX.
Yeah, this is BLX. So this is
a more recent.
More recent.
But it was our first BLX.
Yeah.
So that was the reason we printed this as a contingency plan. But we didn't really have to use it at all. Fingers crossed that this video won't crash you guys. But this is the video of the procedure being done. You want to?
Yeah, so it's speed up 4 times so we can go straight to the point, but a minimal traumatic extraction of the tooth and a removal of the tooth happens. We confirm everything. We confirm the buccal plate. We decide to move ahead with the plan. You see here the guided kit for the BLX system being used. Really cool thing there.
Those are the velo drills.
Those are the velo drills and the handles attached to the sleeve as well, so it frees your hand. Most important step, the whole process, it's to align those dots in the guide, confirm primary stability. And this is, first time the abutment is going in, you're still trying to find out, okay, this is exactly where it goes, right? So the timing was captured, and now the crown going to go over that abutment. The crown has timing too. So if it's off, the crown may be sideways. So,
And we shortened that because of her anterior protrusion was very heavy on that.
exactly.
So
Yeah.
that was one of the things we had to do to allow that. One of the unique things about the BLX implant is that prosthetic connection, the Torx connection is absolutely amazing. Extremely precise. It gives us 6 different positions, so it's going to give you more opportunities to get the timing right than
Yeah.
just a CrossFit. So we use this slide just to highlight the fact that those dots get aligned with that timing there. So very important. You see, he had a little bit more turn to do to get that timing just right, so we can deliver the provisional. Very simple. Once we confirm that little flowable composite on the variobase abutment, we seat the provisional, light cure it, and that's plenty to hold it in.
Plenty.
Very hard to remove it when we do something like that. So here you have post-surgery PA. You did the dual zone technique on this?
Yeah, dual zone was done. The gap in the soft tissue was addressed.
Yeah, and then in 10 weeks, we brought the patient back for their final impression. Again, you can see here we tried the best to get the shade right with these milled provisionals. It's probably one of the weaknesses of them. I think with time, the materials will improve, but very opaque and very hard to get the colors that we shoot for sometimes.
Yeah.
But the patient was fine with this. We did an intraoral scan to maintain the digital workflow. And we shared this information with one of our colleagues, Alexander Wunsch, that runs Zahn Technique Lab down in South Florida, and he made our restoration.
Yeah, so this is here a reference you're gonna have on your PDF file as well, the copy of our lecture. This is for especially for the colleagues that are using the three-shape trios. There is a pathway how to copy the provisional and give your lab that extra information for the emergence profile.
This is kind of like a customized impression coping, where
Yep.
you're just capturing the shape of the provisional, which in essence is what a customized impression coping does. And this shows you real quickly how that's utilized in the laboratory to transfer that emergence profile, right?
So now your lab can start developing, pretty much copying and pasting that portion of the final restoration that it's exactly like your provision. So there is no gap between the restoration of the tissue, or there is no compression of the tissue that you already maintain. You didn't even develop, you maintain that tissue.
Yeah, the important thing, we spend time shaping that tissue. We want to deliver a restoration that supports it appropriately, and that's what this does. And this shows you this slide. This is actually an impressive image here, because what does that highlight, Luis?
Yeah, so the red is the soft tissue captured really fast after you just remove your provisional restoration and you do the scan of the soft tissue. You can even, like, there's a tool on the software, right? If you do in 3Shape, that you can freeze the position of the tissue. We do that. But then you see green is the line of the emergence profile created by the provisional. So there is a slightly discrepancy. I don't know if it's,
And that happened within seconds.
we see that happen.
The minute you remove
Yeah.
the provisional, you see that collapse.
I don't know exactly how the clinical relevance will be for that in some cases, but I don't want that. I want exactly like the way that we developed the provisional.
So what's unique is this was a trio scan that was shared with Alexander down in South Florida. The only other things we shared with him were some clinical photos, and we chose to use the angulated screw channel, not because we didn't have screw access line, but we wanted to allow for a little bit more material at the incisal ledge.
Yeah.
And this allows for it. It may be like a 4 or 5 degree correction, but it's just enough for him to get a little bit more of a cutback and better layering in the interior.
It was a really hard tooth to match.
Yeah, very hard teeth. So this is at delivery, beautiful transition zone that was generated, and then you can see the delivery of the definitive restoration. And this patient we actually delivered right before the pandemic.
Yeah.
This was early March, and we're looking forward to following her over time. but she was extremely happy with the outcome. So were we,
Especially when you
and
have an ugly provisional. I
yeah,
told
oh
you it's
yeah,
a benefit. She was like,
yeah.
"Oh my goodness."
We hear that all the time. They're like, "You make provisionals too nice. You need to make them ugly so they
Yeah.
come back."
Here you go.
But with that said, this is where we stand with this patient. Obviously, this is showing you a very short-term follow-up. There's a long way to go here. Hopefully, we'll maintain this architecture long-term and maintain these aesthetics. But the main point of this presentation was to share with you how this digital technology has integrated into our workflow. I already know that there's going to be questions from you regarding Smile in the Box. Smile in the Box is a service that Strawman provides for you to be able to do the synergy workflow and other workflows in your practice without having to outlay tons of money on software
Exactly.
and hardware. So all you have to do to initiate this workflow is to have a CT scan and an intraoral scan or a digital file,
Right.
of that patient, and then they can do all the other steps. Synergy is just the relationship of the dental wing software in being able to allow you to fabricate a restoration prior to an implant being positioned. There's not many software programs, if any, that I'm aware of out there that are not in their beta phases. There's a few beta phases, but
Seamless connection.
yeah,
Not like back doors or
yeah.
jerry riggies. It's just like, they really talk.
Yeah. So this is a unique type of relationship between these two programs, one that you can't find elsewhere. So our early experience is very promising. Very excited on where we've gone with it. Looking forward to doing more, documenting more, and seeing where it takes us. But it's an exciting time with a digital workflow. And we thank you for your patience. I know that this has been a struggle for all of us to get through this, but hopefully you I have made it to the end,
Yeah.
and here are the lecture notes. So bit.ly/SIB-2 is a website where you can download. Actually, that will just download the PDF to your computer, or you can use this QR code if you have a mobile device, and
Just point
or
your
just take a
camera.
picture of the screen, and that gives you both ways to get to that
Yeah.
content. So with that said, thank you, and I think we have some questions,
Yeah. Yeah.
right?
Sorry again
So
for the technical problems. We know like the guys on Strumman are working hard to produce or to give access to this and work hard and to get at everybody. But
Oh, great
sometimes
question. All right, so there's some awesome questions. We'll move forward here. So the first one, what makes Smile in the Box so special in your opinion? I saw that Ali when we Ali asked this and I saw that when we were re-logging back in, and I kind of highlighted it. Smile in the Box gives you an opportunity to experience a digital workflow without having to outlay a ton of money in software and hardware. If you have the intraoral scan and the CT, you could pretty much practice digital workflow
yeah.
procedures without sourcing it to them. There's other providers out there. There's no question. There's many of them, and we've used other providers. We actually have one locally that we use a lot. But what makes Smile in the Box unique is if you're a Strawman user, it just falls in line with everything you may be doing. The next question is, does loading mean only connecting the prosthesis to the implant or actually putting them to work? So that's a great question.
Can I address that one?
Yeah, yeah.
So
I've
this
been talking a
is
lot. So
no,
you
no,
want to
because
talk.
because that one it was something that changed, with the consensus, and I had my you know my point of view on this too, because we used to have two things. It was immediate loading or immediate provisional,
Immediate restoration.
immediate
It
restoration,
was immediate loading or immediate
right?
restoration, and I somehow sometimes still believe that if you can't have the teeth come in contact, right? But
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 I'm converted now. So
yes,
they converted me.
yes.
They did a good job explaining. So the thought behind when we're talking about immediate today everything will be immediate loading, because you cannot prevent the patient from function. Yes, we do remove, as you saw in some of the cases, the centric contacts and lateral contacts, right? But if the patient put food there, if the patient, try to put something in between the teeth, it will have function. Or sometimes even the tongue. Patients will create force on the implant. So the belief is the implant will be loaded one way or the other, the point that you connected that restoration.
Yeah, Ali,
But
that was a great
I think
question, though.
it's control loading to some point. We do ask our patients to avoid chewing on that side, on those center incisor teeth, to avoid incising, right,
Yeah.
cutting things, at least for 6 to 8 weeks. But I agree with you. It's a little bit, you know. Well, you said that you immediate loading, but you remove
No, the
the
question
contact.
was are you actually putting them in contact? Is that still defined? If it's out of contact or into contact, is it still considered
Yeah, we
loading?
put in contact
Yeah. So
when it's multiple implants splinted together. When it's a single implant, we try to minimize center contact
yes.
and lateral
So
exclusion.
the thing is, like if you've done enough with implants, I've had situations where we don't put anything on the implant, and you put an you put a flipper in there, and that flipper contacts the implant. You're loading the implant. The implant moves or fails.
Mhm.
So yeah, I understand where you are. It's controlled though. If you can control it and make sure you protect it, that's very key. Let's move forward. Great questions here though. So the next one is: do you have any tips on minimizing heat generation on type 1 bone? If you know the osteotomy site will be very hard beforehand, and will you decide not to use the fully guided system?
Okay.
So if you're going in type 1, kind of granite, what are you going to do? Obviously, new twist drills,
Yeah.
right? And then design the template to get the irrigation there. So you're going to have to reflect the tissue, right? You wouldn't
So
go flapless.
that picture that we have on the presentation, to all the things that will influence, will play a role. And you said, the speed of the osteotomy, new twist drills, designing a guide, knowing that allowed you for cooling. It's not that every guided surgery will generate more heat. It's just a risk for it. You just need to be aware. And another very important thing is respect the protocol given by the specific company. So Straumann has a protocol for the tissue level, the bone level, the BLX, the BLT, according to the bone quality. So you will see that with harder bones, you're going to use more drills. You're going to stage the osteotomy more to try to prevent heat. And sometimes we forget that. We get like one protocol that we have and we keep using, but you need to modify the protocol
Do
according to the
you do
bone.
you in those situations maybe do a little more pumping motion of the twist drill into the site? You go in and out a little more than you would in a type 3 type situation, or
Yeah,
not?
yeah. I think you need to do. It's always an exercise to force yourself, especially when you're learning, when you're novice clinicians, to remember like you need to do that, not just put a pressure down. But I think the more important is new drills. Make sure that your drills are not, right at the cusp to be changed. So know when to change your drills and respect the protocol that was developed by the company for this
Drilling
specific.
speed, the size, and so
Yes.
forth.
What the
That,
Velos will be even easier because the Velos they have only one drill speed.
yeah, Novello is going to have much more efficient cutting.
Yeah.
Dr. Green with the next question: if you don't have an intraoral scanner, can you mail a model in, or is it better to have a local lab make an STL file?
So I know Straumann in Arlington, they do have a lab technicians on site and they can do some of that and you can send casts there. But if you have a certified lab and they have a whole list of labs that work with you, they can create that STL file. The
I
same
wouldn't
thing's
be
gonna happen.
yeah.
They will do that for you at Arlington. But if you have a lab that closer to you that you don't need to ship and you
Yeah,
send that and you can
you save on shipping
just
costs.
yeah.
And Dr. Green, remember, if you do that small box workflow, you can introduce your technician into that workflow because the small box is only going to take you to a provisional. You still have to move to a definitive. So I would integrate them if they have a scanner, get them in on the front end, and that may be a workflow that they end up doing the busy work for you, and you just sit on the back end and enjoy it. So I know there's a lot of labs that are interested in that because they don't want to take on that early part of the planning and so forth. I'm sorry for anonymous, we don't know the costs. I would say that when we did, I haven't looked at the smile in the box cost for the single, but for the full arch, they've been very competitive, if not less than a lot of the other companies out there.
Yeah, and it's hard like because we highlight the a la carte,
Yeah,
so it's
because
hard to
it's
talk
modular.
about cost
Yeah.
and what are you doing, but
I don't think it would be difficult to find out the costs. So that would be some. I would ask the Strawman
I
representative.
see that Bethany's here, so you can ask maybe
Yeah,
Bethany. She's
Dr.
with so.
Hamilton said, "How do you make such amazing photos?"
Well,
We use all of his.
I went to Boston and I take Adam Hamilton's photography course.
Yeah, yes. So we've been doing photography for a long time. Long time. Next one. Have you done one abutment, one time concept using smaller box? That's an awesome question from Anonymous.
Yeah.
And the one abutment, one time would be with the, we want to, because that last treatment we could have done that is, and the one abutment would be when you do your spine on the box workflow, you get a variable base abutment with a provisional, and you can deliver it.
Yeah, but he's if I'm thinking what he's
He's saying
thinking,
leave it,
yeah,
but you can't leave it because it's a screw retained. In addition to that, you're going to have to retrieve that off of it.
yeah.
The one abutment being placed at the time of implant positioning limits you to a cement retained restoration.
We actually show a picture that Adam Hamilton, that's here. They did a custom zirconian abutment and then delivered the provisional the same day. And then the idea was to remove the provisional later on, leave the zirconian abutment there, and cement the final restoration.
But in that situation, if you're not working off the original planning, you're going to have to pack cord and get a scan of that.
Yeah.
Right. So while I see the benefits that placing that abutment at the time of surgery, never removing it, are really attractive, really handcuffs us on the restorative end. And I'm pretty much 100% converted right now to screw retained restorations. So that eliminates my ability for one abutment one time at this point. But what I was kind of leaning towards until I looked at his face and he said I was wrong was one abutment for everything. One abutment for the provisional, and he utilized the same abutment with the definitive because it's a variable base abutment is a definitive abutment. So you could just order the crown from your lab. Next question. We're almost done. How was your experience with that peak guide center from our friend Dr. Guzman?
Yeah, Guzman, you know that. So I'm gonna give you my my honest opinion. It is awesome because it's quite annoying when you need to hold. So the question, Dr. Guzman, for the ones that are not familiar, you saw in the last case a white peak sleeve that get added to the guide for the BLX, and it's the evolution, the new design for the sleeves. The key element of that sleeve, it's locks in with the handle, so it frees your hand from holding the handle. Awesome, I think.
And also the handle doesn't move up in some situations. When you have multiple people going, you may think it's seated fully and the handle kind of bends or moves up. It snaps it down.
Now I'm gonna be a little
critical,
like picky about it.
Oh,
it's slightly too tight. So when you're removing the handle, sometimes it's hard. Sometimes the sleeve can come together if it's not glued. Sometimes the guide come in a little bit. So I already mentioned this. We had some KOL meetings, and I think Strawman's working on the tolerance. So it's I'm really being picky, but it's really cool.
Anonymous asks, how often do you need to adjust the provisional for timing with the variable base, or do you rotate the implant? So first answer is we haven't had to adjust. I don't think the timing was off on any of them.
No.
So we've been very fortunate with timing. But if we were going to do an issue with timing, I think we may rotate the implant unless the BLX is not a good implant to rotate backwards.
Exactly.
So you wouldn't want to do it on the BLX. You don't want to go backwards, counterclockwise with the BLX. So the other ones, even with a tapered implant, it's not always wise to back it up.
Yeah.
So if you move forward, it just all depends how much of timing are you talking about.
So the temptation to move the implant, it's natural, and you can do that. And I would tell you that some situations we did like a little bit, and probably was because I didn't notice on the guide that actually need a little bit more. The risk, and what was mentioned, the problem is the tread pitch. So now if you have an implant with a very aggressive tread pitch, It's like, oh, I just need to move a little bit more. Then you keep in mind that you can create discrepancies on the apical coronal position of the implant. So now the implant's a little bit too deep, you know. So I'm not gonna lie to you.
So maybe probably
It
not
happens
a quarter
clinically. Yeah.
turn or an eighth of turn, but maybe, a really minor adjustment. It's not a problem though to take out the timing and the provisional
Yeah.
and bond that in with some composite. But we fortunately have not had to do that just
Yeah.
yet. So do we prefer? This comes from Justin, Dr. Kang. Do we prefer screw-retained versus cement screwmentation? We do both. I mean, I think the question, if you're saying screw retained like a one piece that's on a gold abutment, we're not doing those as much as the screwmentable where we're taking a variobase and cementing a restoration that has a screw access hole in it.
Yeah.
But we don't do many. If you're asking as far as screwmentable goes, a variobase custom abutment restoration.
Yeah.
We don't do many of those unless we're having to do an angle correction. But now, if we're doing an angle correction, we go to the angulated screw channel, right? And the
Yeah.
angulated screw channel allows us to go with one restoration and the abutment.
There's two things that they did on the next generation of the Verabase that was introducing the different heights for your superstructure, right? So the 1 millimeter, 2 millimeter, 3 millimeters of the tissue cuff, and introducing the AS, the angulated screw channel. That really it make really hard. It makes it really hard to not use it.
Yeah.
You know, to justify using other weapons it's a lower cost compared to a more customizable option. We spend a lot of time in the treatment planning to have the screw access on the ideal situation. So
I think
um,
Justin may also been saying, do you do a titanium custom abutment
yeah,
and then cement a restoration onto it? And we don't do many of those. We do a lot more of the variobase
but have that one on
designs.
your back
But
pocket.
it's a
Sometimes
good
you
one.
need to.
You know where it's a really good one to have that in your back pocket if the patient wants a full gold crown and a molar site. You want to do full titanium cutback, mill it out of a titanium abutment, and then just do
Yeah.
a nice thin gold crown there and make it screw
That's
retained.
exactly what somebody just
How about
mentioned.
CAD titanium abutment with crown luted? Yes.
Yes,
Yes.
great. It's a good
Yeah. So that's
option.
what we were just saying.
Yeah.
And that's an option. But now you start saying, what do you want through traversing through the tissue, right? So if you do with a titanium and bring the cement line closer to the mucosal margin, now you have titanium underneath there.
Yeah.
And you could introduce a zirconia transition zone in
Yeah.
a restoration. But the negative to that, if we were debating pro con, the con to that is we have a cement line now that's deep. So that cement line, while it's not in the bone or at the level of the implant, it's deeper. So you want to make sure that you have, and that cement line's introduced extraorally, most often by your lab, but microscopically it's a gap.
And this
So
option even
this
like
may be another option.
a little more attractive now because I know so you can request with a gold hue with titanium nitrate. So you can do that option, the titanium custom abutment, gold hue, and bring the margin up. And I think it's a great option too.
Hey,
Great questions, actually.
some great comments. We appreciate the nice feedback. And we are at the end. There's no more questions. We've made it 2 hours. And look, my Apple Watch is telling me my heart rate and my blood pressure right now. So, anyways, we thank you for your time. Hope you enjoy those notes, the link to the notes, and we will actually be presenting at Straumann's Immediacy Symposium. Very similar presentation because it's on the same topic. So that's going to be next Thursday. Hope to have you join back. Hey, Bob Vogel. Shout out from Bob. Thanks, man. So anyways, take care, and we'll see you later.
Thank you, guys. Thank you
Thank
again.
you.